do you see any molecular strategies that might come into play, either some data from studies that may identify what molecularly determined aberrations might determine particular therapies? Do you guys foresee that?
When I listen to that question, what I'm hearing or what's going through my particular mind is MRD status. Not so much, molecular subtyping up front, but MRD testing at certain time points. And so I'm curious if that will be used to make different decisions along the pathways, because we see that in other, indolent lymphomas. So I could foresee a situation where you do a couple cycles of R-CHOP followed by, MRD testing, and then you take a pathway based on what you see thereafter.
All right.
I would say
Go
that.
ahead,
And one more thing too is I think doing assays for the T cell microenvironment and the ratios of CD4 to CD8 cells may help to predict, who may never respond to a bispecific or, fail a CAR. And can we actually tease those people out before you put them through therapies that they're not going to respond to, right? Because that's definitely one way to save costs. Why put someone through a CAR T if you know that, they're going to fail in 3 months? And same thing with the bispecific. Like, are their T cell milieu, is that ratio tipped in the wrong direction where they're going to have, escape and it's not going to work? So, I think MRD, is so important, especially when we talk about, treat to progression versus finite therapy. I think sometimes we overtreat and probably could stop sooner in certain situations. But especially when you're talking about upfront therapy as well. And also looking at that T cell microenvironment when you talk about these T cell directed therapies. So anyhow,
is anybody concerned potentially that there's some noise about CAR T therapies and secondary malignancies, and that when these are used upfront, that maybe that risk will be so much higher? Or is the feeling so much that maybe the patients who are heavily pretreated were already predisposed, and maybe the risk is not as high in the newly diagnosed? Does anybody have any comment on those types of concerns?
So I'll comment that, a lot of news or buzz this last year and change about secondary T-cell malignancies after CAR T therapy, a subset of which are not even just regular old T-cell lymphoma, but it's not just true for lymphoma, for myeloma as well. In fact, some of the cases or myeloma cases that have been presented so far wasn't just plain old T-cell lymphoma, it was specifically CAR T lymphoma. It was a T-cell lymphoma that had the CAR integrated into it. Whether the integration was absolutely causal, there was some, chip pre-malignancy that was almost T-cell cancer already, that some of those are a little bit unclear. But yeah, there are probably some causally related CAR T-cell lymphomas, but then probably a bunch of T-cell lymphomas that, as you hinted, the patients were at higher risk for anyway. Patients with B-cell lymphomas have a higher risk than the average person for getting T-cell lymphomas. So already that was a risk even before they get CAR T-cells. And then I think no matter what, all of those risks add up to something smaller than the big risks of CAR T-cell therapy, which are infections, not just the CRS and the icons, but infections 3 and 6 months later. So hard to worry about that interesting, horrific side effect that's going to be quite rare compared to the common side effects. So yes, it's important. Yes, it warrants discussion with the patients, but I don't think it affects the risk-benefit analysis of should this patient get CAR T-cell or not, because it's going to be pretty small risks compared to the other things.
And I think there's a lot of other risks to add to that. I have a patient who has Parkinsonism, that we think is related to his therapy.